हाँ जी, वेरी वेरी गुड इवनिंग एवरीबडी, गुड इवनिंग, है ना? ऑल वेल, सब अच्छा चल रहा है बच्चे? सो टुडे व्हाट वी विल डू इज वी विल कंटिन्यू विद व्हाट वी हैव स्टडीड सो फार, बट you can see on the bottom what I have written. Today I will not show you anatomy, I will actually show you diseases. So my goal will be to make sure that you understand how to look at the disease in, if we are looking at a case, how to understand and how to apply it in the disease. And most probably, we will take in the next class, we'll finish the CNS imaging, and after that we'll start with chest x-ray. So today we will primarily focus on brain diseases. Okay, so good evening everybody. I can see all of you are very very excited, and let's start with the today's class. So to start with today's class, I want to ask you two questions first. Okay, I want to ask you two questions first. Question number one is, let's see if you can answer. In the last class, I talked about a dye that we use in MRI called as gadolinium. Okay. In the last class, I told you about a dye called as gadolinium. My question is, gadolinium is a large molecule, and when we use in radiology, we actually use it in chelated form. That means we might be using something like gadolinium DTPA. Okay, so hello everyone. Yes, okay, so what we will do is, I want to answer a question and I want to ask a question to all of you. Let's see how many of you can answer this question to me. Okay, so gadolinium DTPA. My question is, gadolinium DTPA, or the gadolinium chelate that we use in MRI, can it cross blood-brain barrier, or it cannot cross blood-brain barrier? Anybody? So what is blood-brain barrier? So blood-brain barrier is in the brain, if these are your capillaries and these are your endothelial cells of the capillaries, in brain, the endothelial cells have tight cell junctions. Not only do they have tight cell junctions, they also have a continuous basement membrane around them. They have a continuous basement membrane around them. In other body parts, the capillaries have a fenestrated basement membrane. In brain, you have continuous basement membrane, and then you have astrocyte foot processes contributing to the blood-brain barrier. Okay. My question is, gadolinium cannot cross blood-brain barrier. Correct. Because it is a large molecule, it cannot cross all these barriers and it cannot go into the brain. My question is, two questions are, what will happen in inflammation? Second is, what will happen if you have an aggressive neoplasm in the brain? Anybody? What will happen to the blood-brain barrier? This is the first slide, beta. This is the first slide I'm writing today for the late joiners. Okay, tell me. Gadolinium cannot cross blood-brain barrier. It cannot cross blood-brain barrier is the first statement I've given. What will happen in the inflammation and what will happen in the neoplasm? Any one of you? In inflammation and in neoplasms, I'm sure you know, in inflammation, there will be, better tell me, the capillaries will become leaky. In inflammation, the capillaries become leaky, and when the capillaries become leaky in brain, the blood-brain barrier is disrupted, and then the dye will go into the brain. So that means if I have an acute inflammation in the brain, that area will take up dye because of hyperemia, because of disruption of the blood-brain barrier. Everybody clear? Yes. Second is neoplasm. And we all know, even in a neoplasm, the tumor will take up dye. Do you agree? Because of neovascularization. So the tumors in the brain will not be supplied by the normal capillaries. They would have tumoral vascularity or angiogenesis that happens in a tumor. And those vessels would be leaky because they would not have blood-brain barrier, and the tumor would be vascular. So that means I'm introducing to you a term called as enhancement. एनहांसमेंट मतलब डाई का अपटेक होना, inflamed areas and neoplastic lesions would enhance on MRI. Everybody clear? Okay, do you get the logic? Okay. To demonstrate this logic, I want you to see a small video with me. Okay, let's see if you can understand and answer. Okay, I will pause it first. Okay, now this is how what is happening in inflammation. Okay, let's see what is happening in acute inflammation. In acute inflammation, the capillaries dilate. Okay, so there is hyperemia, there is increased blood flow, and what happens in acute inflammation is, okay, the capillaries begin to leak and there will be edema surrounding. Do you agree with me or not? So inflammation would lead to hyperemia, increased blood flow, as well as leaky capillaries. Okay, that is the principle number one that I want you to know. So whenever I will show you inflammatory lesions in the brain, I will talk about uptake of dye, I will talk about edema. Okay, everybody understands? Great. So once you are able to understand this, it makes my work very easy. Second thing I want you to do is, I want you to look at a tumor. What is a tumor? Tumor is a solid tissue where the cells are proliferating, and then you have this neovascularization happening, the angiogenesis happening. So again, do you agree tumors will also enhance most of the time if they are high-grade neoplasms, because the blood-brain barrier will be disrupted and there will be a neovascularization? Do you agree? Yes? Okay. And gadolinium is chelated because in itself it's a metal and it would be poisonous. So what we use as a dye is actually a gadolinium chelate. Everybody understands this? Okay, great. Okay, now, so once you understand this, I will now go back to my original work. I'm removing the foot line that the children were finding disturbing. So this is the first moral of the story, and this is the only thing that you need to write right now. Gadolinium chelates cannot cross the blood-brain barrier. But in acute inflammation and neoplastic lesions, which are aggressive neoplasms, you will find enhancement. Everybody clear? Okay. So once you're clear with the concepts and you can see how, everything is interlinked, I will now take you to the first image. Okay. Let's see the first disease together, bacho. Okay. We will see a disease together. Okay. Everybody, are you clear? Okay. My question is, what body part are you looking at? We are looking at brain, definitely. What investigation are we looking at? We are looking at MRI, definitely. Okay. Bache, I will show you. Just keep looking at it. Okay. Now, question is, we are looking at a brain MRI. Very good. Now tell me, okay, my question is, I'm sure some of you will be able to answer. If this is a brain MRI, what sequence is this? What MRI sequence is this? What is the color of CSF? The CSF looks dark. What is the color of gray and white matter? What is more dark? What is more dark here? The white matter is more dark. So we know the gray matter, as compared to gray matter, the white matter is dark. CSF is dark. That means we are looking at a FLAIR MRI. Do you remember all this? Okay. So the reason I'm telling you this is because if we had not done the basics, you could not have come so far. Now we can see this is a patient with a brain MRI and we can see the FLAIR image. Okay. Okay, bacho. Now any one of you can answer. Where is the disease located? Is it unilateral or bilateral? Is the disease unilateral or bilateral? Bilateral. Symmetric, asymmetric? It is a asymmetric. Bilateral regions. Okay. But are they located in the gray matter or white matter? Are they located in gray matter or white matter? So we can see there is asymmetric bilateral regions in the white matter. Okay. The disease is appearing more bright than the normal myelin. The normal myelinated white matter should be should be dark. Remember, on a FLAIR image, the white matter should be dark. The disease is bright. Okay. So there is some problem in the white matter, and the white matter is myelin. Myelinated tissue has some problem, and there is asymmetric bilateral involvement. Okay. Now, if I ask you now, white matter has myelin. Can you name a CNS disorder in which you have autoimmune response to the myelin? Okay. Can you name a CNS disorder in which you have autoimmune response to the myelin? What, anybody? So that is multiple sclerosis. Okay. Is it possible that are we looking at multiple sclerosis? This is my doubt. Why? Because I see asymmetric, bilateral, white matter hyperintensities. Okay. So I have a doubt now. Am I looking at multiple sclerosis? Okay. Very good. I can see most of you are saying. Some of you are saying, okay. Some of you are saying, okay, bachcho, Guillain-Barré syndrome. Is it Guillain-Barré syndrome? No. Guillain-Barré syndrome is an autoimmune demyelinating illness of the peripheral nervous system, while multiple sclerosis is an autoimmune demyelinating illness of the central nervous system. Now, how to confirm? Okay, how should I confirm that this is multiple sclerosis? Okay, to confirm that this is multiple sclerosis, I need to look at the pathology slide. Okay. This is how multiple sclerosis looks like on a pathology slide. Please see with me. Please see with me. Okay. Please see with me. This is a vein. Can you see the RBCs inside? There is a vein which has RBCs. What do you see around the veins? When I look at around the veins in this slide, I can see mononuclear chronic inflammatory infiltrate. Now we know if there is an autoimmune disorder, bache socho, autoimmune means okay, we are thinking that we have an enemy, but there is no enemy, it is our own tissue. The immune system is thinking there is an enemy and is launching an attack. Okay, so must be a chronic inflammatory infiltrate is seen. So in MS, on microscopy, we can see perivenular lymphocytic infiltrate or monocytic infiltrate. Everybody clear? Okay, so we can see perivenular. The key word is perivenular. The inflammation is around the veins. Now, I will show you a concept. Okay, I want everybody to concentrate. Okay, concentrate in listening and write only what I am telling you to write. Only this much. Okay, nothing else. Now, bache, tell me. Now, suppose this is our lateral ventricle. Suppose this is our lateral ventricle. You remember the lateral ventricle had anterior horn, posterior horn, inferior horn. Okay. So lateral ventricle is lined by ependyma. Okay. You remember the ventricles are lined by ependymal cells. Below the ependyma, we have veins. Okay, let me explain. Below the ependyma, we have subependymal veins. These subependymal veins are oriented perpendicular to the superior surface of the lateral ventricle. Okay, let me repeat. In MS, you have, okay, perivenular inflammation that is characteristic on pathology. When I look at anatomy, listen to me, when I look at anatomy, the subependymal veins are seen perpendicular to the lateral ventricle. Now, anybody can think and answer, what will happen around the veins in MS? Inflammation. And what will this inflammation cause? It will cause demyelination. That means in MS, demyelination would also be seen oriented perpendicular to the ventricle, shaped like fingers. In MS, you will have demyelination also around the veins, shaped like fingers going perpendicular to the ventricle, described by a pathologist called as Dawson. Hence, these are called as Dawson's fingers. Are you aware of this word? Very, very important for your MCQ questions. They will always ask you, in which condition do we see Dawson's fingers? The answer is multiple sclerosis. But the question is, why are the Dawson's finger formed? Because MS is perivenular. The key is in pathology, and that is where the integration happens. My question to you is this. Now, tell me, based on what we have learned together, do you think the image that I have shown you, do you think these are Dawson's fingers? Do you think these are Dawson's fingers? Anybody? The answer is we cannot say, because this is a axial image, while the Dawson's finger will be better seen on a sagittal image. Are you clear with the planes now? Do you clear? Okay. Okay. Are you clear with this? Okay. It is perivenular. Artery would not be collapsed like this, bache. Artery collapse nahi hogi, goal hogi. So what we are looking here is, to see Dawson's finger, we need a sagittal section of the brain. Okay. Now let me show you. Let me show you. Okay. I want all of you to look at this sagittal flare MRI that you're looking at of the brain. Can you locate the disease for me? In the sagittal section, if I now try, you can see this finger-like oval disorders perpendicular to the ventricle. What do you call them? Dawson's finger. These are called as Dawson's finger. Are you clear with this or not? Dawson's finger. Everybody understands? Seen in multiple sclerosis. Okay, seen in multiple sclerosis. Everybody understands now that how to look at these things. Now you have understood it, you will never get it wrong. You know that once I show you like this in the exam, this is multiple sclerosis. You will be able to mark it in the exam. Everybody understands? Clear? Okay, brilliant. Okay. So once you are able to see the disease now, but now the key is, if you notice a difference in you, earlier you were trying to mug up the image. Now we are trying to think and get to the answer. And thinkers always beat the judgers. You understand? Half of the world is only judging everybody else. They are not thinking at all. Okay. So if you are thinking, you will win. Okay. The key is in thinking. Okay. My question is, okay, I will tell you now. Listen to me, bachon. Listen to me. Okay. Do you remember I told you in flare, if there is a disease, it will appear hyper intense. CSF signal is suppressed, beta. So do you understand? Abhi CSF ko maine suppress kiya. That is why the periventricular disease is better seen. Otherwise, the CSF would also have been white and it would have been tough. That is why we are looking at a flare image. My question to you is, okay, let's see if you can answer. Beta soch ke batana hai, okay? Now, the second keyword about MS is the clinical profile. MS should be relapsing remitting disorder. याद है? MS का जो clinical profile है वो कैसा होता है? Relapsing remitting. Okay. Now tell me, बच्चे सोच के बताना. If you tell me, I'll be very happy. Okay. Now how will I know that this disease is relapsing remitting? That means if it is relapsing remitting, it should have some old lesions and some new lesions. समझ पा रहे? कुछ पुरानी इन्फ्लेमेशन होनी चाहिए, क्रॉनिक, है ना? कुछ ओल्ड लीजन्स होने चाहिए, कुछ न्यू होने चाहिए. Do you agree कि नहीं? If it is a relapsing remitting disorder, it would have some old lesions, some नहीं. भाई पहले relapsing remitting का होता है मतलब कि you have a disease, फिर ठीक हो जाती है, फिर दोबारा होती है. तो अभी अगर relapsing remitting है तो कुछ नया लीजन भी होने चाहिए, कुछ पुराने भी होने चाहिए. क्वेश्चन ये, कैसे पता चलेगा? How will you know that there is acute inflammation present? बच्चे tell me, how will you know? बच्चे, how will you know we need to do? This is a plain flare image, but how will we know? क्या करें? We need to give contrast. Now you understand why we require contrast. We need to give contrast. Do you agree here or not? Do you understand now? If it is an inflammatory lesion, acute inflammation will have hyperemia, leaky capillaries, and that lesion will enhance. Okay? Okay, now let's see. Bache, please see the pathology book. Okay, once you see the pathology book, you will realize what I'm teaching. Okay, now see with me. Okay, bacho, please see the two images now. It is very conceptual. I need your full attention here. Please focus on what I am teaching rather than you're racing your mind into past and future. The problem is that most people are unable to be in the moment. They either are ahead of the moment or behind the moment. The key is in listening to the teacher and understanding. In exam, they will ask whatever I am saying, nothing more, nothing less. Okay? So please listen to me. Okay? Thank you. Okay. Now see this image. This is another patient where you can see a T2 weighted image. And the second image I am labeling as a contrast enhanced MRI. Okay? The first image I am labeling as T2 weighted image. Okay, second is a contrast enhanced image. But okay, listen to me. In the first image, there are abnormality in the white matter, multiple asymmetric. Okay. While when I do a contrast study, I can see enhancement. So in contrast study, when the dye is taken up, we say enhancement. I can see enhancement in only these two lesions. Okay, listen to me, beta. Listen to me. Okay, listen to me, everybody. Okay, the first image is a T2 weighted image. We could see 4 or 5 lesions. Okay, we can see 5 lesions on a T2 weighted MR. On a contrast enhanced, the dye is taken up only by 2 of them. Can you tell me why and explain it to me? Now, if there is contrast enhancement, that means these lesions are acutely inflamed. These are acute plaques. So then what about other plaques which are not enhancing? We could see them on a T2 weighted MR, but they are not taking up dye. They must be old lesions. That means this is a relapsing remitting disorder. This is called as, okay, notice the word that I'm writing. In medicine book, they will call it as dissemination in time. समझ पाए? ये दोबारा बताओ. Are you clear with this or not? Concept बना कि नहीं? रटना नहीं है बच्चे, हमें समझना है. So that is why you need contrast in radiology. Okay, now you are starting to understand that when I have to look at an inflammatory lesion or a tumor, I have to give IV contrast to assess. If it is inflamed, acutely inflamed, the capillaries will be leaky. Okay, and I will see enhancement. Now you can see and understand, bache, that there are multiple demyelinating lesions. But Sabira, you are asking the same question again and again, and I'm not answering because your question is incorrect because you do not know it. Okay, so try and understand. If I'm not answering something, it might mean that it is just a first year concept. You remember in first year they said autoimmune disease affecting the myelin, but why it is happening we don't know. Idiopathic, but pathologists have found a perivenular predominance. Okay, listen to it. Okay, so there were multifocal lesions on a T2 weighted image. Okay, but all of them are not enhancing. That means the disease is relapsing remitting, and the term that we use is dissemination in time. Okay, T2 पे old और new दोनों दिख रहे हैं, लेकिन contrast पे सिर्फ नए वाले lesion दिख रहे हैं. Everybody understands now? अब ठीक है, contrast पे केवल वही दिखेगा जो acutely inflamed है, तो यानी वो नया lesion है. T2 पे सारे दिख रहे थे, and then that is how we can see dissemination in time. Are you clear? Are you clear? Okay, now see, this is called a dissemination in time. That means the disease is not happening at one time, it is a relapsing remitting disorder. यानी समय के चक्कर में बीमारी में फैलाव है. Okay, now understand this. Okay, listen to me. Look at the third MRI image. Can you see a focal lesion in the spinal cord also? Cervical spine maybe, in the spinal cord, there is a focal demyelinating plaque. So now tell me, is the disease limited to brain or do you see it in the spinal cord also? Is it limited to brain or is it seen in the spinal cord also? It is more widespread. It is seen in multiple compartments. It is in the brain as well as in the spinal cord. So when you see multi-compartment disease, in MS we call it dissemination in space. Okay. So these are the typical MRI findings of multiple sclerosis. We always use the word dissemination in space and time. बच्चे ट्यूमर दिखाऊंगा ना बाद में. Okay, don't run. Okay, don't run. Try and understand the concept. Don't race here and there. I will show you tumors also. Bachche, don't worry. Okay, everybody understands? Okay, so we see this is the word that you will find written in Harrison, but now you know the meaning of the words, that now you don't need to mug up. MS in radiology will show dissemination in space and time. Are you clear with the words? Okay, now I could have simply said ye line yaad kar lo, but I want you to understand. That is the key. It will take some time, but once you understand, you will never forget. Now, bachcho, I will give you a question to solve. Okay, I'm removing whatever I've written here. I will create an MCQ. Let's see how many of you are able to answer. Okay. Now, in the same image, now I am writing a question. A HIV positive patient has MRI shown to you. When contrast enhanced MRI was done, the lesions were non-enhancing and they had no mass effect. CD4 count of the patient is less than 200. What do you think we are dealing with? Now suppose I am creating a visual question, same photo, but the history is different now. Now I am saying everybody, but a space concept matlab multi-compartment spread dikhna. So we had a disease in the brain as well as spinal cord. We will call it dissemination in space, multi-compartment disease. Okay, okay, everybody understands. Now my question is this. Okay, anybody, a HIV positive patient with CD4 count less than 200, MRI shows asymmetric white matter hyperintensities. Symmetric, asymmetric, asymmetric. Okay, you can see asymmetric white matter hyperintensities, non-enhancing. What do you think we're dealing with? Okay, now see. Now I want to introduce to you a viral infection that happens in HIV patients. Are you aware of the fact in HIV, if the CD4 count is less than 200, there is a risk of opportunistic infections. Okay, so there is an opportunistic infection in HIV which is called as JC virus. Okay, what is JC virus? John Cunningham virus. Okay, now let's see why the disease is non-enhancing. Why do you think I have written non-enhancing? बेटा non-enhancing लिखा मतलब डाई का अपटेक नहीं हो रहा बच्चे. अगर डाई का अपटेक नहीं हो रहा तो उसका क्या मतलब है? That means it doesn't look like a acute infection like toxoplasma. Infection होती तो उसके response में हम inflammation करते. If you have an attack in the body, we in response to the attack we do inflammation and that would lead to dye uptake. And tumors would have vascularity, so that doesn't look like lymphoma because tumor में तो vascularity होगी. So there is an infection in HIV called as JC virus, John Cunningham virus. This JC virus affects your oligodendrocytes. Listen to me, beta. Don't run. Listen to me. बच्चे भागेंगे नहीं. Okay. This JC virus affects the oligodendrocytes. Now think with me. Think. बच्चे सोचें. जितना मैं कह रहा हूँ वहां सोचिए बेटा. आगे पीछे नहीं. Or what is the function of oligodendrocytes? Oligodendrocytes have the same function as Schwann cells have in peripheral nerves. Their function is myelination. So if oligodendrocytes are diseased, what will not happen? Myelin formation will be defective. Okay, there will be myelin formation will be defective. Everybody understands. So myelin formation will be defective, then you will have white matter disease. Okay, this is called as progressive multifocal leukoencephalopathy. In short form, we call it PML. Okay. Now, please imagine with me. Please imagine with me. Listen to me. Now, this JC virus is going to affect your oligodendrocytes. So today, listen to me. Listen to me. One oligodendrocyte is diseased. In that area, myelin formation will be defective. After some days, another oligodendrocyte is diseased. Another area will become abnormal. Then another. So disease is progressive multifocal. It's a progressive disorder which is multifocal, and that is why we call it as PML. Okay, so PML would also have white matter abnormality. Can you guess it with the name? Yes, the name itself is telling us. The name is leukoencephalopathy. Progressive multifocal leukoencephalopathy has to cause abnormality in the white matter, and there is no mass effect. मतलब ventricle को दबा नहीं रहा. So it again goes in favor of that we are not looking at a tumor. You understand this? Some of you were saying lymphoma because HIV can have lymphoma also association, but then the tumor would compress the surrounding structures. I have written no mass effect. So this is how MCQs are integrated manner framed. Are you clear? So you understand this or not? How we approach the question? When I say a white matter disorder in a HIV positive patient which is non-enhancing, no mass effect, that makes me think of PML. Now you might say कि सर वायरल इन्फेक्शन है तो यहाँ पे इन्फ्लामेशन नहीं है. बच्चे देखिए, ये वायरस माइलिन को इन्फ्लामेशन से डिस्ट्रॉय नहीं कर रहा, ये ऑलिगोडेंड्रोसाइट्स में इंक्लूजन्स कॉज कर रहा है. You remember this or not? Viral inclusions in oligodendrocytes are happening, and that is why it is not functioning properly. So there is no inflammatory destruction of myelin. In multiple sclerosis, we saw contrast enhancement because it is an immune disorder leading to inflammatory destruction of myelin. Everybody understands the concept? समझ आया? Okay. So that is why it is not taking up the dye. Okay. Hypointense नहीं ना बच्चे, समझ नहीं रहे आप. एनहांसमेंट मतलब होता है डाई का अपटेक करना या ना करना. हाइपर इंटेंस का मतलब होता है T2 या फ्लेयर में ब्राइट है कि नहीं, वो अलग है, एनहांसमेंट अलग है. व्हेन आई से एनहांसमेंट आई मीन अपटेक ऑफ डाई. एवरीबडी अंडरस्टैंड्स? Okay, patient will come to you with neurological deficits, like you might have visual field defects or other neurological deficits. Okay, now everybody understands. Now the second question is, let's see how many of you are able to answer my next question, beta. Okay, I'm going to give you a question. Let's see if you can solve. Okay, let's see if you can answer. बच्चे सोच के बताना, हाँ? Okay. Okay. Beta, I'm actually repeating 10 times, beta. Just try and focus here, please. I am again saying, let's learn this thing. I've learned over the years that children are unable to focus on the class. They're always distracted. So what happens is, if you're unable to focus on what the teacher is saying, you will always miss the bus. Please listen to me. Come with a blank mind. Don't think anything else. Whatever I'm telling, only focus on that much. Okay? Now listen to me and focus on this. Child with, okay, listen to me. Developmental delay shows symmetric white matter abnormal signal. The ventricles are normal. What should you suspect? Okay, let's see if you can answer. Okay, बच्चे, do you remember contrast image जो होती है वो T1 weighted होती है. Okay, so it's a T1 weighted image obtained after giving IV contrast. Okay, so that is the reason. Okay, I will again and again repeat all this. Don't worry. Okay, I will show you multiple diseases and gradually you will get a hang of it. Question is, see the sample questionnaire. Okay, this is the clinical vignette. Okay, this is the clinical vignette. You have to think of it and answer. The age group is pediatric. The disorder is not an acute disorder. We are not looking at viral encephalitis or something like this because there is no acute fever and altered sensorium. The problem is developmental delay. लंबे समय से चल रही है बीमारी. This is not a short duration illness. The problem is symmetry. As soon as I see symmetry, I start thinking of, is it something more systemic? Is it a genetic disorder? Is it an inborn error of metabolism? It's all symmetric. It's not asymmetric. Multiple sclerosis, PML were asymmetric. Here we are looking at symmetric problem in the white matter. Okay. So this is where we think of inborn error of metabolism or genetic defects which have problem in myelination. Now, let me ask you a question. Suppose in this question, I add a word large head. What diseases come to your mind? Okay, child with developmental delay, symmetric, white matter abnormal, what the ventricles are normal, the child has a large head size is large. Now, so far, the radiology is not there, but it is there inside in the integration part. So, one of the diseases that I have to think of is a GFAP gene mutation. Okay, have you heard of this before? A GFAP, glial fibrillary protein mutation. This genetic defect where the GFAP gene is mutated is called as Alexander's disease. Alexander's disease in brain has frontal lobe predominance. Any one of you bright young children will be able to tell me what will you find in pathology on microscopy of a patient with Alexander's disease. Alexander's disease में बच्चे बताऊंगा सिखाऊंगा ध्यान से देखेंगे. Alexander's disease में microscopy में क्या मिलेगा? Because it is a problem with, listen to me, it's a problem with GFAP gene. You will see multiple scattered non-specific rosanthal fibers. Do you remember this? Rosanthal fibers are also found in pilocytic astrocytomas, and you will also see them in Alexander's disease. Okay. Now, so let's see the keywords. Some of you are unable to understand what I'm trying to teach you is the art of looking at a clinical vignette. Okay, so clinical vignette is built with building blocks. The building blocks were age, pediatric, insidious onset, developmental delay, symmetric problem in the white matter, large head. If I add them with frontal lobe involvement, rosanthal fiber, it becomes Alexander's disease. It is also called as fibrinoid leukodystrophy. Okay, Alexander's disease is also called as fibrinoid leukodystrophy. Fibrinoid means fiber wali, rosanthal fiber wali. Leuco means white matter, safed ki. Dystrophy means kharabi. Okay, so fibrinoid leukodystrophy is another name for, are you clear? Alexander's disease. Very good. Okay, second question. Another disease which will lead to large head is Canavan's disease. Another disease which will lead to large head is Canavan's disease. But mind you, Canavan's will be having diffuse involvement of the entire white matter. Canavan's में कोई frontal parietal ऐसा predominance नहीं होगा, सारा area involve होगा, diffuse involvement होगी. And when I do MR spectroscopy, you will find elevated levels of N-acetyl aspartate. Elevated N-acetyl aspartate. You remember the enzyme that I taught you last time? Aspartoacylase deficiency. Okay. Okay, I will show you the images after this, beta. I'm just trying to tell you that how to approach a white matter disease, beta. Okay, these are all white, मतलब ल्यूको लिखा, ल्यूकोडिस्ट्रोफी, तो MS क्यों नहीं है, कैनावान क्यों है, कैसे सोचेंगे ना बेटा? So we need to look at the history also, ना? That is what I'm teaching you. Are you clear? Okay, now हाइड्रोसेफलस नहीं होगा इनके अंदर, इन सब में वेंट्रिकल नॉर्मल है, माइलिन में इडीमा होने के कारण लार्ज हेड है यहाँ पे, वेंट्रिकल नॉर्मल है यहाँ पे. ओके, वेंट्रिकल का साइज नहीं बढ़ा बेटा यहाँ पे. ओके, वेरी गुड बेटा. सेकंड क्वेश्चन. नाउ आई वांट यू टू अंडरस्टैंड, इट इज वेरी डिफिकल्ट. आई वांट यू टू स्पेंड सम टाइम विद मी बेटा. इफ दीज आर योर gyri, below your gyri in the brain you have U-shaped short association fibers connecting the two gyri, adjacent gyri. इनको कहते हैं सब cortical U fibers. Okay, just below your gray matter you have short association fibers called as subcortical U fibers. Okay bache. Okay, now these are association fibers connecting the adjacent gyri. Now these subcortical U fibers are last to myelinate, these are last to myelinate, and they have slow turnover of myelin. Okay, subcortical U fibers are last to myelinate. Bache Shreyansh, okay. Now what I want to tell children is, please don't ask me where to write down, but I've already told you, beta, whenever I am writing, you need to write in the books, okay, in the notebook. If I'm teaching an image, then you come back to the image book. If I'm teaching on theory, go back to the notebook. Okay. See, the key here is that what are rosanthal fibers? Rosanthal fibers are non-specific inflammatory response fibers that you will find when you go back to your pathology and when you read about pilocytic astrocytomas, beta. Okay. So now see with me. Okay, try and understand. So please see. The key here is that more we understand things, more our lack of understanding of the past gets exposed. But then we need to focus on the present so that we can understand what the teacher is telling us. Please see with me. Subcortical U fibers are last to myelinate and they have slow turnover. Okay, bache? Now tell me, beta. Tell me. So imagine if there is a disease which affects the myelin turnover. Suppose there is a lysosomal disorder affecting the myelin turnover, or you have a peroxisomal disorder affecting the myelin turnover. What will happen? There will be sparing of subcortical U fibers. So the word that I want you to remember, lysosomal disorders and peroxisomal disorders which affect the myelin turnover will spare the subcortical U fibers because they have a very slow turnover. They are unlikely to be affected in these diseases. What am I talking about? I am talking about these disorders, beta. Please see with me. There is a lysosomal disorder which is due to deficiency of aryl sulfatase A. Can you name it? There is a lysosomal disorder which is due to deficiency of aryl sulfatase A. It is called as metachromatic do you know this? Leukodystrophy. Okay. So in metachromatic leukodystrophy, you will have sparing of subcortical U fibers because it's a lysosomal disorder. In this disorder, I want you to understand there is perivascular sparing. That means, although there is problem in the myelin, how do I know there is problem in the myelin? Beta, tell me. I only read the word को तोड़ के देखेंगे बेटा क्या लिखा है. ल्यूकोडिस्ट्रोफी, सफेद की खराबी, नाम में लिखा हुआ है. एंड दैट इज द चैलेंज इन फर्स्ट ईयर एमबीबीएस. फर्स्ट ईयर का जो बच्चा एमबीबीएस में याद कर मेटाक्रोमेटिक ल्यूकोडिस्ट्रोफी, मेटाक्रोमेटिक ल्यूकोडिस्ट्रोफी, मैडम पूछ रही है एग्जाम में क्या इसमें व्हाइट ब्रेन इन्वॉल्व होगा, पता नहीं मैम. अरे बेटा, इट्स रिटन इन फ्रंट ऑफ यू, ल्यूकोडिस्ट्रोफी, ल्यूको मींस व्हाइट. So it's a problem of myelination, but it spares the subcortical U fibers and it spares the perivascular white matter. Now try and imagine with me बेटा, मेरे साथ सोचेंगे बेटा, सोचना है, ये सोचने वाला काम है बेटा, याद करने वाला नहीं है. If this is your white matter, okay, if this is your white matter, okay, in metachromatic leukodystrophy, some areas will be normal because they are around a blood vessel. This appearance is called as tigroid pattern. You might have read this in your Harper, in your biochemistry, but today I'm telling you the reasoning. So that is why there is white matter abnormality, but around the vessels there is normal area. So we call it tigroid pattern. Okay, tigroid pattern in white matter seen in metachromatic leukodystrophy. Clear? Okay. Second question, beta. I will show you all this, beta. So that's why I'm telling you in theory first. Then there is an enzyme called as beta galactosidase. You remember beta galactosidase deficiency is called as? Anybody? Beta galactosidase deficiency is called as Krabbe's disease. You remember Krabbe's disease? Dr. Crabbe described it. So we say Krabbe's disease, which is also called as, because the cells are globoid, so we say globoid cell leukodystrophy. Here the keyword is thalamic involvement. Krabbe's disease not only involves the white matter in your brain, it also involves, okay, it also involves thalami. Okay, so once it is written in the question, you start thinking of Krabbe's disease. Thalamic involvement in a white matter disease, Krabbe's disease. Okay, so in these diseases, the head size will be normal or small, but they will never write enlarged. So once they say head size enlarged, we go towards Alexander's and Canavan's. If they say subcortical U fiber sparing, I go towards metachromatic leukodystrophy and Krabbe's disease. Okay. Now there is a X-linked peroxisomal disorder called as X-linked adrenoleukodystrophy. It is called as X-linked adrenoleukodystrophy. Everybody clear? Have you heard of this before? This X-linked leukodystrophy, adrenoleukodystrophy, has predominant involvement in the posterior part of the brain. So you will see parieto-occipital involvement. And typically, the question will say boy. It will not say child, they will say boy. Tell me why. Because the disease is X-linked. Because the disease is X-linked, they will say a boy with developmental delay, and the MRI will show, okay, MRI will show, okay, parieto-occipital involvement. Now, these are how to approach leukodystrophy. But now I will stop the theory and I will take you to practical. Okay, we'll look at it in images. Okay, let me zoom the image fully. Look at the first question here. A child with developmental delay. Child with developmental delay. What do you think is the problem in the MRI? Okay, I changed the question. I'm saying this is a question saying a boy with developmental delay. What is the abnormality? Where is the abnormality, बच्चे? है ना? देख के बताना बेटा. बीमारी कहाँ है, आगे की तरफ है कि पीछे की तरफ है बेटा, है ना? सो इट्स अ बॉय विद डेवलपमेंटल डिले, डिजीज कहाँ है? इज इट एंटीरियर, इज इट पोस्टीरियर? द डिजीज इज पोस्टीरियर. सिमेट्रिक, एसिमेट्रिक? वी कैन सी सिमेट्रिक. सो बीमारी कहाँ पे है बेटा? ओके, बीमारी कहाँ है बेटा? देखो, बीमारी जो होती है वो बहुत ब्राइट दिख रही है फ्लेयर में, फ्लेयर में ये बहुत ब्राइट है. दिस इज द डिजीज. कहाँ पे है? व्हाइट मैटर में. सिमेट्रिक है कि एसिमेट्रिक है? सिमेट्रिक. There is symmetric disease in bilateral posterior part of the brain. We are start to think of X-linked adrenoleukodystrophy. And I want you to appreciate, it is slightly difficult, but I'm sure all of you are so intelligent student that you are encouraging me also. If this is your gyri, okay, ये gyri है, so can you appreciate, okay, I'm zooming it to the maximum, can you appreciate there is a U-shaped area of white matter which is actually normal? Okay, can you see जो बीमार एरिया वो बहुत white हो गया है, but below the gyrus there is subcortical U fiber sparing. This is X-linked adrenoleukodystrophy. Now, second question. Okay. Second question. Child with large head, MRI shows abnormality, symmetric. Gray matter, white matter? White matter. The MRI shows symmetric white matter abnormality. Which lobe? Is it occipital lobe or is it frontal lobe? Where do you think? Where is the problem in the image? Is it occipital lobe or the frontal lobe? Okay. So in this child with large head, okay, let me just open the pen. Yeah, there is frontal predominant symmetric white matter abnormality. What do you think? What do you think? What will you find on his microscopy? On his microscopy, you will find fibers that you see in pathology called as Rosenthal fibers. This is a genetic disease called as Alexander's, described by Dr. Alexander. Are you clear with this one? So that is why I was teaching you theory and some of you were getting disturbed. But I know that you don't even remember the names from your biochemistry. So I need to tell you the names. Then I need to come at radiology. You understand this or not? See, radiology is a super specialty. Even if you don't know the name of the disease, how can I make you understand? So that is why I made you familiar with the names. Okay? Very good. I can see all of you are now intelligent. Now, next is a child with large head. The question is saying his head size is clinically large. White matter is shining white all around. है ना? White matter पूरा ही brain में खराब है. And then there is a MR spectroscopy image which is showing a tall tower of NAA. Everybody understands? Okay. So let's see an answer. बच्चे बताएं. Okay, the key here is that we need to go from basics and come up. Okay, so you have to have patience with me. You have to go at my pace. Okay, so this is Canavan's. Are you clear now? Dr. Canavan described this disease, accumulation of N-acetyl aspartate. It is an amino acidopathy leading to myelin problem. Correct. Now you can see. Now at least I'm able to instill a word leukodystrophy in your mind. Leukodystrophy, safed ki kharabi. Okay, brilliant. Now you can see it. So this is Canavan's disease. N-acetyl aspartate accumulation. Very good, beta. I'm so proud of you now that you're picking up. The key is in picking up. Okay, key is not in thinking कि सर मुझे पहले नहीं आता था. कोई बात नहीं, माफ करेंगे अपने आप को. We'll forgive ourselves and then we will learn. Okay, so the key here is, sir, I don't remember biochemistry. It is okay. It is okay, but let's today learn it. Okay, the key is today. Okay, key is not in yesterday. Okay, see this image. Same patient. T2 weighted flare. Same patient, two images. Okay. Flare, which part? Where is the disease? This is the disease. This is the disease. This is the disease. This is the disease. Okay. Now tell me, is this disease symmetric or asymmetric? It appears symmetric. Gray matter, white matter, beta. White matter. We can see symmetric involvement of the white matter. Yes, yes, correct. So we're probably dealing with something inborn error. But now when I look at the T2 weighted image, In the T2 weighted image, what I can see is in the white matter there is abnormality. Along with the abnormality, there are tiny strands of normal looking area which is giving an appearance like this. Can you give a name to this appearance that I'm trying to draw? This appearance is called as tigroid pattern. This is called as tigroid pattern. So now tell me, name a white matter disorder, a leukodystrophy which has tigroid pattern. The answer is, anybody remembers? Metachromatic leukodystrophy. Okay. So in a nutshell, I have now, this is Canavans for the child who wants to see it here. Okay. So it will be written for you. It will be written in front of you in the exam that look at the FLAIR MRI, look at the T2 weighted image, and then make a diagnosis. Okay. Are you clear? So the key here is, I have shown you how to approach a white matter disease. If they say HIV positive, how to think about it. If they say relapsing remitting neurological illness, how to think of it. What is Dawson finger? Why we say dissemination in space and time, and how to approach leukodystrophies. Now, in the next part, now what I want you to understand is, okay, listen to me everybody. Now suppose an infection, suppose this is my brain, suppose an infection, listen to me beta, okay, an infection comes to, okay, adrenoleukodystrophy beta, adrenoleukodystrophy, this one was the adrenoleukodystrophy, you know, everybody. Okay, so posterior involvement is the key in adrenoleukodystrophy. Okay, now child boy will be written. Okay, my question is, beta, listen to me now. Okay, my question is, tell me, suppose you have infection in your brain, infection. Okay, suppose I have infection in the brain, a focal area of infected pathology. How will my body respond? What do you do in response to inflammation, beta? सोच के बताना है. What will you do in response to inflammation, beta? Tell me. So in response to infection, you will develop inflammation. Do you understand all this? बच्चे जहां infection आएगा, उसके आसपास inflammation होगा. Do you agree with this or not? Yes, correct. There will be inflammation. Inflammation would have hyperemia, leaky capillaries. Remember we talked about all this, increased blood flow and capillary will be leaky and there will be surrounding edema. So if there is a inflammatory lesion in the brain, an infective lesion in the brain, there will be surrounding inflammation, surrounding edema. Do you agree? Yes. Okay. So, beta, subcortical U fibers are only spared in lysosomal and peroxisomal disorders. Did I make you write this? Yes. Okay. Now, please see an answer, beta. Now, what do you see in this image? This is a contrast enhanced MRI. What do you see in this contrast enhanced MRI? We can see a ring-like enhancement. There is a ring-like uptake of dye like this. So that means this must be a disease which is inciting hyperemia around it, inflammation. So we call it. So the term that we use here is, better listen to me. You will always find this in your exam. Ring enhancing lesion. Okay. Now the third year students, sometimes they will find the disease name difficult, but don't worry. This is everyday affair. Don't worry. Listen to me. Ring enhancing lesion in the brain. When I see this, it tells me there must be some infection like neurocysticercosis, tuberculoma, toxoplasmosis, okay, brain abscess. Common thing, all three are infection, all four are infective problem, hai na? NCC, tuberculoma, toxoplasma, abscess. But mind you, even metastasis can look like this. So not every ring lesion will be infective. Usually it is infective, NCC, tubercular, toxoplasma, brain abscess. But the problem here is sometimes you will have metastasis also looking like this. Everybody understands? Okay, clear? Okay, it would be written in the question that we are looking at a contrast enhanced MRI beta. लिखा होगा वो. Everybody understands? Okay, now my question is this. Let's look at them one by one. Okay, before we go back, let's look at them one by one. Okay, let's see one by one. But suppose I'm writing a parasite which has gone to the brain. I'm saying neurocysticercosis. Okay, initially, listen to me, children, but don't be afraid of it. Okay, it will be written, Asmita, I have written, it would be written in the question paper that it is a contrast enhanced study. Okay, लिखा होगा आपके लिए, डरे नहीं. Okay, now tell me, neurocysticercosis, initially when it reaches the brain, it is viable. Okay, शुरू में this parasite is alive. Okay, everybody understands? Parasite alive है, जिंदा है. Okay, brain में आ गया लेकिन जिंदा है. So it looks like this. It looks like a cyst which has a scolex inside. Okay, are you clear? Okay, now tell me, cyst with scolex appearance. This stage of NCC is called as vesicular stage. बच्चे भूल जाएं तो वेसिकल का मतलब क्या होता है? Vesicle means something which is filled up with clear fluid. Cyst means something which has clear fluid. It's a cystic parasite. Okay, are you clear? Are you able to understand this? Vesicular stage of NCC is viable. Now tell me, okay, the question is, बच्चे टीबी अभी दिखाया मैंने, अभी दिखाऊंगा ना बेटा, wait and tell me. Okay, listen to me and tell me, will you have inflammation around this parasite or not? Okay, you have a viable, zinda parasite in your brain. Now, will you have inflammation around it or not? Tell me, yes or no. एक पैरासाइट है आपके ब्रेन में आ गया, क्या ब्रेन उसके आसपास इन्फ्लामेशन दिखाएगा कि नहीं दिखाएगा? Will you have inflammation around it or no? Okay, the answer is there will be no inflammation. Surprise, surprise, है ना? मुश्किल है ना बेटा? सच तो मुश्किल है, लेकिन एक बार सीखेंगे कभी गलत नहीं होगा. Okay, now see with me. Why there will be no inflammation is, inflammation क्यों नहीं होगी? Because when the parasite is alive, listen to me, when the parasite is alive, the cell membrane is intact. Did they teach you in immuno and micro कि the cell membrane is not immunogenic? Cell membrane जो होती है ये immune response नहीं incite करती, immune response तो protein के खिलाफ होगा. So when the cell membrane of the parasite is intact, वो alive है, there will be no inflammation. Okay, understood? So when there is no inflammation, do you think you will have any edema surrounding the parasite? No edema. Do you think you will have any enhancement when I give the dye? No enhancement. क्यों? जब इन्फ्लामेशन ही नहीं है तो फिर डाई का अपटेक क्यों होगा? डाई का अपटेक तो तब होता है ना जब इन्फ्लामेशन होती है, ब्लड ब्रेन बैरियर डिसरप्ट होता है, ब्लड फ्लो बढ़ती है. आर यू क्लियर विद दिस? So now most people get it wrong in the exam. Okay, because everybody wants to do big things. If you notice now on your screen, I have only written few words. Okay, I have not written big words, no essay, no long, only few lines. But that is the key in the exam. They will say vesicular stage of NCC will appear like a ring enhancing lesion with edema. Answer is false. Vesicular stage will have no edema, no enhancement. It will appear like a cyst with scolex. Everybody clear? Okay. Now, okay, second question, beta. Let's see if you can answer, beta. Okay, I will answer. Listen to me, beta. Listen to me. Now this parasite begins to die. Now the parasite begins to degenerate. So we will say degenerating stage. हमारा दुश्मन है लेकिन अब मर रहा है. The degenerating stage. Okay. My question is, let's see if you can answer. If a parasite is dying, listen to me. If a parasite is dying, the fluid inside the parasite, will it remain clear or will it become turbid? If the parasite is dying, the fluid will start becoming turbid. Fluid will become turbid like a colloid, so we will call it colloidal stage. क्या नाम दे दिया मैंने बेटा? Colloidal stage. Okay. My question is, what will happen to the cell membrane if the parasite is dying? अगर कोई मर रहा है, तो cell membrane will start rupturing. If the parasite is dying, the cell membrane will start rupturing. Okay, when the cell membrane ruptures, are you able to see immediately the proteins will come out and our body system will understand this is the enemy? Understand? Immediately. अब क्या होगा बताओ? All the WBCs will come. अरे दुश्मन है घेर लो इसको चारों तरफ से. It's the enemy. We need to control him. Okay, चारों तरफ आ जाओ. Okay. So all the inflammation will start happening all around the parasite because of the protein which are released. Okay. So there will be an inflammatory ring-like rim around the parasite. Now you get it here. Now I'm sure most of you will get what is happening. You understand here. Jahan inflammation hai, there will be disruption of the blood-brain barrier, and the dye will be taken up in a ring-like, smooth ring-like fashion. Okay, that is why you see ring enhancement. And now, whenever there is inflammation, the capillaries will leak and the fluid will seep into the surrounding tissue. So you will have surrounding edema plus. Everybody understands? You will have ring enhancement. Okay, बेटा अब समझ आया कि रिंग लाइक एनहांसमेंट मतलब वहां पे इन्फ्लामेशन है, वहां पे इडीमा है, एंड वी अंडरस्टैंड द एंटायर कॉन्सेप्ट नाउ. सो दैट इज व्हाई दिस स्टेज इज मोस्ट लाइकली टू बी सिम्प्टोमैटिक. ब्रेन में एक जगह इडीमा होगा, सूजन होगी, तो पेशेंट को सीजर पड़ेगा. पेशेंट विल बी सिम्प्टोमैटिक. Now do you understand the concept here? That viable stage is usually asymptomatic. There is no edema, there is no ring enhancement. It is the colloidal stage, which is the one which is usually symptomatic, which is with edema and ring enhancement. Okay, now final part. Okay, final part, beta. I am sure now you are understanding the story now. Now the parasite is dead. Now the parasite dies. Okay. Now, when the parasite dies, what happens is there is a rule. Okay, listen to me. There is a rule. There is a rule in war. It's a rule of war. When the enemy is dead, you pay respect to the enemy. Do you agree here or not? जो लड़ाई चल रही होती है, जहां enemy मर जाता है, so then the soldiers, they do not actually destroy the dead body, they respect the dead of either side. So here also, in body also, when NCC is dead, we give respect by putting calcium over it. Okay, so we put calcium over it, make a tomb, and we call it nodular calcified stage. Okay, so dead stage is nodular calcified. There is no edema at this stage. There is no enhancement. Edema enhancement तो तब होगा जब लड़ाई चल रही होगी. लड़ाई का मतलब इन्फ्लामेशन है. डेड हो गया तो क्या इन्फ्लामेशन होगी वहां पे? डू यू एग्री? Everybody understands? Yes. Now you have the concept. Now you are able to understand the entire war happening. I will now take you to this another image to understand. Okay. So this is how different stages of neurocysticercosis, which is a very frequent question in our exams. I hope you are able to get it. Now I want you to look at an X-ray with me, beta. X-ray. Okay. Let's see a X-ray and let's try to see the problem. Okay. Let's see this X-ray of the pelvis. Can anybody look at the X-ray and tell me where is the problem? The problem, is it in the bone? Is it in the muscles? Okay, look at the X-ray. Yes, colloidal is the name of the degenerating stage, beta. Okay, yes, beta. Okay, anybody now? When you see now, the bones look okay. You can see there are multiple calcification in the muscles. And the calcium fibers, if you note the calcification, it is oriented along the muscle fibers. It is the axis of the muscle fibers. Now in the muscle you have spindle like cells like this. Muscle में इस तरह से spindle like cells हैं. Okay. Let me get back. So when the cysticercus goes to the muscles, okay, when the cysticercus goes to the muscles, it is oriented in the muscle spindles and it takes the shape of the muscle spindles like this. Let's see how many of you are able to follow my point. This NCC, the cysticercus, when it goes into the muscle, it takes the shape of the muscle fibers like this. This is called as rice grain appearance. This is the rice grain calcification that you see in myocysticercosis. Are you clear? Myocysticercosis, you will have rice grain appearance. This is how it looks like. But I'm sure, can anybody of you tell me, have you ever seen in your ophtha OPD, eye OPD, okay, a patient with proptosis because of cysticercosis? Why? Because this parasite can also go into the extraocular eye muscles. So it may go into any muscle and that muscle will have swelling, edema because of inflammation, and you will have proptosis. Okay, you will see it very commonly in the IOPD. Okay, are you clear? Okay, very good. Oh, very good. Now let's see the next picture. Okay, let's try to understand the next picture. Okay, everybody now look at the next picture, bache. Look at the next picture. Okay, again in this next picture we are able to see ring lesions, but the ring lesions are like this. Okay. In the next picture you have ring enhancing lesions, but the ring enhancing lesions, they appear to be joined together. They are all sticking to each other. In English we call it, they appear to be conglomerate. आपस में एक दूसरे से चिपक के they form a bunch, गुच्छे की तरह बन गए. We say conglomerate. Okay. Okay. So in the next image you can see conglomerate ring enhancing lesions. Okay, everybody clear? Conglomerate ring enhancing. So when I see this, how many of you have ever seen in your clinics, किसने भी देखा कि sometimes a patient with TB will come to you with lymph nodes, you touch those lymph nodes in the neck and you find them all sticking to each other. सारे lymph node आपस में TB में चिपके होते हैं ऐसे. What do you call it? You say matted lymph nodes. That means tuberculosis has a property of conglomeration. TB के lesions आपस में जुड़ते हैं. So when I see this conglomerate ring lesions, now I know this is not NCC, this is tuberculoma. Are you clear now? Once you see conglomerate ring lesions, now we know this is TB. वो तो जैसा हमें कॉलेज में सिखाया था, जुड़े हुए हैं तो TB होगा. Perfect. Now anybody, why is the center of the tubercular lesion not taking up the dye? जो पेरिफेरी में तो इन्फ्लामेशन के कारण डाई का अपटेक हो रहा है, बट सेंटर में क्यों नहीं हो रहा? Why is the center not taking up the dye? Because the center is necrotic. Remember I taught you this? TB में तो सेंटर में necrosis होता है. So that is why it is appearing like a ring. सेंटर में necrotic area है, आसपास inflammation है. That's why it's looking like a ring. Okay. Now please see, if I do MR spectroscopy in tuberculosis, you will find lipid peak. Do you recall? Because of necrosis, in TB, you would have lipid peak. TB of the brain parenchyma is called as tuberculoma. TB of the meninges is called as tubercular meningitis. TB of the brain parenchyma is called as tuberculoma. TB of the meninges is called as tubercular meningitis. Okay, any one of you can answer this question, beta. Okay, anybody can try and answer. Let's see how many of you can answer. TB meningitis on radiology will always show basal exudates. Okay, brain के base पे जहां पे हमारे पास, you remember all this or not? So brain के base पे the inflammation will be there and the capillaries will be leaking and exudative fluid will be collecting. You will find basal exudates, and you will also have TB also leads to end arteritis in the brain. It leads to inflammation of the arteries, and that may lead to areas of infarcts, especially in the basal ganglia. These two words, if written in the question, are pointing towards tubercular meningitis. Are you clear? Are you able to understand this? Tubercular meningitis leads to these two words in radiology. They will say basal exudates, area of infarcts. You should be able to get the answer as tubercular meningitis. Okay, this is how the lipid peak would look like. I have marked for you the lipid is elevated in tubercular lesions in the brain. Are you clear with this or not? Everybody understands the concepts? Okay, very good. Now my question is, let's see if you can answer. Now is a very difficult MD level question coming your way. Contrast enhanced MRI, diffusion weighted MRI. Okay, what do you see in both of them? Okay, very good. Contrast enhanced MRI, diffusion weighted MRI. This contrast enhanced MRI reveals a ring enhancing lesion. That means there is an inflammatory lesion which is having hyperemia and blood-brain barrier disruption around it, ring enhancing lesion. And along with it, you can actually appreciate edema around it. Okay. Can you see, bacha, there is a ring enhancing lesion with edema. That means inflammation hai, beta, inflammation hai. But on the diffusion weighted MRI, it appears bright. Diffusion weighted MRI पे वो चीज bright होती है जहां particle motion नहीं होती. So if the particle motion is not there, that area will appear bright on diffusion. Let's imagine now, suppose somebody has, बच्चे सोचना है, sinusitis और otitis media, है ना, sinus या कान की infection या कोई congenital heart disease है, valvular congenital heart disease है कोई, है ना, shunt है कोई. Now in these people you have a foci of infection. The focus of infection probably because of the valve के अंदर या कहीं पे paradox embolism है या sinus में या ear में infection है. Okay, now that infection, listen to me, infection goes into the brain. जहां पे infection होगी वहां पे क्या होगा बच्चे, क्या सिखाया था मैंने, दुश्मन आएगा तो क्या करेंगे, inflammation. So surrounding it you have inflammation, है ना, inflammation होगी, inflammation. फिर साथ में क्या हुआ, edema होना शुरू हो गया, edema. फिर when this goes for a long time in a pyogenic infection, if it is going on for the long time, some enemy cells, some our soldiers, माने कुछ हमारे WBC, कुछ enemy के bacteria, they start dying and a thick liquid starts to accumulate inside, and this liquid is called as pus. This liquid is called as pus. Pus is a thick, viscous liquid. Okay, so in the pyogenic inflammation, what will you have? You will have pus inside. If there is a long-standing chronic inflammation, some your soldiers which are WBCs will be dead, some bacteria will be dead, and pus is there. Pus is thick and viscous. If the pus is thick and viscous, okay, what will happen to the particle motion? There will be no particle motion. And this is called as brain abscess. Okay, and these are the reasons why you develop a brain abscess. समझ आया? ब्रेन एब्सेस है ना ये, तभी तो वो उसका वो उसमें कंजेनिटल हार्ट डिजीज में भी पैराडॉक्स एम्बोलिज्म नाम का एक कॉन्सेप्ट है जो आप पढ़ेंगे जब आप उसको पैथोलॉजी में टेट्रोलॉजी ऑफ फैलेट में देखेंगे. वहां पे भी इन्फेक्शन कहीं पेरिफेरी में हुआ लेकिन राइट टू लेफ्ट शंट होने के कारण ब्रेन में पहुंच गया. इट इज पॉसिबल. ओके, सो दैट इज व्हाई. सो ब्रेन एब्सेसेस आर एसोसिएटेड विद कंजेनिटल हार्ट डिजीजेस लाइक टेट्रोलॉजी ऑफ फैलेट, ओटाइटिस मीडिया जो आप ईएनटी में पढ़ेंगे, साइनोसाइटिस में एब्सेस होता है. अगेन यू विल रीड इन ईएनटी. Okay, are you clear with this or not? Okay, that is the key here. So if you see a ring enhancing lesion in the brain which is bright on diffusion, think of abscess. Everybody understands? Abscess क्या होता है? Pus collection बेटा, pus collection. Okay, so we have to see both of them together. बेटा दोनों को साथ में देख के समझ आ रहा है. एक से तो वो एनसीसी भी हो सकता था, टीबी भी होता, but when I see both the images together, I know I'm looking at abscess. Okay. Now my question is this. Let's see if you can answer a question. Okay, again I will give you a clinical vignette to solve. Okay. 70-year-old male has new onset seizure. MRI done reveals a ring enhancing lesion. Okay. At his gray-white matter junction. What is the most important cause that you should think here? Okay, 70-year-old male with new onset seizure. MRI shows a ring enhancing lesion at gray white matter junction. Okay, look at the age, 70 saal. Okay, what should I think of? At his age, ring enhancing lesion might well be a metastatic lesion. It could be metastasis. 70 साल का आदमी है, हो सकता है metastasis हो. Metastasis brain में सबसे common कहाँ होता है? What is the most common site of metastasis in the brain? And this was asked last year in NIMHANS exam. The most common site of cerebral metastasis is gray-white matter junction. Okay, most common site of cerebral metastasis is gray-white matter junction. Very good, beta. Any one of you can answer, बच्चे है ना? कोई भी बच्चा मुझे बताए कौन सा कैंसर हो सकता है ये? 70 साल का आदमी है, ब्रेन में मेटास्टेसिस है, तो विच प्राइमरी कैंसर विल यू थिंक ऑफ? व्हाट प्राइमरी विल यू थिंक ऑफ बच्चे? बेटा 70 साल की उम्र में पहले एनसीसी थोड़ी सोचेंगे ना बेटा. ओके, एनसीसी वुड नॉट बी ब्राइट ऑन डिफ्यूजन बेटा, है ना? सो वी विल थिंक ऑफ लंग कैंसर. Lung cancer is notorious to spread to the brain. Which type of lung cancer is notorious to spread to the brain? कौन सा ऐसा लंग कैंसर है जो ब्रेन में स्प्रेड करने के लिए मशहूर है? उसका नाम है स्मॉल सेल कैंसर ऑफ द लंग. ओके, विच लंग कैंसर टिपिकली स्प्रेड्स टू द ब्रेन? स्मॉल सेल लंग कैंसर. इसीलिए स्मॉल सेल लंग कैंसर की स्टेजिंग में वी डू MRI brain, while non-small cell की staging में we do not do MRI brain. Are you clear? So small cell cancer में you always do a MRI brain because you know the propensity to spread to the brain is very high. And that is why in small cell cancers there is a term that I want you to remember with me. We use prophylactic cranial radiation or radiotherapy. If somebody has small cell cancer of the lung, even if the brain does not show any metastasis on MRI, still prophylactically you give radiotherapy. Because we know microscopic metastasis hoga hi hoga. Are you clear with this or not? Are you able to understand this? And this is a last year NEET question. You might have seen this. In which remember, in which cancer do we need to give prophylactic cranial radiation? The answer is small cell cancer of the lung. Why? Because it has microscopic metastasis, it has very high propensity to spread to the brain. Okay, this is how you think clinically. If you learn to think clinically, you will always be able to solve all the questions. Okay, are you clear with this? So I have so far taught you how to look at multiple sclerosis, how to look at infections, HIV. So let's look at one more question based on HIV. HIV positive patient, CD4 count less than 200, shows a ring enhancing lesion, okay, which has a eccentric target like appearance. That means it is like a ring, but where the parasite is, there is some eccentricity. What will you suspect? Okay, but a prostate cancer typically goes to the bones. Prostate cancer bone में जाता है, brain में नहीं. Brain की propensity ज़्यादा lung cancer की होती है बेटा. Okay, so when I show you bone metastasis, I will ask you about prostate beta. Okay, anybody? Ring enhancing lesion with a eccentric target like appearance, CD4 count less than 200 in HIV patient, think of toxoplasmosis. Most characteristic cause of ring lesion in a patient with HIV with a eccentric target appearance is toxoplasmosis. Okay, in the exam they might even say what is the drug of choice here. So it is important that in an integrated question they might not ask you radiology, they might ask you pharmacology. What is the drug of choice for toxoplasma? That the children will answer themselves. Okay, I will not tell you. It is up to you to find out the drug of choice. Okay, very good. Now you understand how integrated questions are framed and how we are able to help you form them. Okay, now let's go further. Now today I will now go further and I show you some other diseases. Let's see how many of you can answer them. What part of the brain is I am outlining? What is this part of the brain? Heart-shaped part. What could this be? This must be the midbrain. Okay, this must be the midbrain. So if this is the midbrain, my arrows are at substantia nigra. Okay, my arrows are at substantia nigra. Okay, now the substantia nigra looks like this tail, so we'll call it, it looks like swallowtail in a normal person. On a high quality MRI, substantia nigra looks like a swallowtail. Everybody understands? Very good. Now, second question. In the second image, the substantia nigra shows abnormal appearance. The normal swallowtail appearance is absent. What do you think is the disease? You already know. As soon as I said substantia nigra, you start thinking of Parkinson's disease. Remember nigrostriatal pathway abnormality? Yes. So absent swallowtail sign is seen in Parkinson's. So swallowtail appearance is a normal appearance. What is happening in the substantia nigra in Parkinson's? In Parkinson's, there is something called as alpha-synuclein. Have you heard of this before? There is something in pathology called as alpha-synuclein. So in Parkinson's, there is alpha-synuclein deposit in the substantia nigra, which is alpha-synucleopathy. Okay. Now, I want you to tell me, name a condition. Let's see how many of you can answer. Name a condition in which you have a more widespread throughout the cerebral cortex. You have a more widespread alpha-synucleopathy, which is involving the entire of the cerebral cortex, and the patient comes to you with dementia. Name the condition. Are you able to understand? Parkinson's is a localized alpha-synuclein deposit in the substantia nigra, nigrostriatal pathway, But a more widespread alpha-synucleinopathy, which leads to dementia, is called as dementia of Lewy body. Have you heard of this before? Dementia of Lewy body dementia. Clear? Very good. So the key here is it involves the entire of the cerebral cortex. But do you recall what part of the brain was involved in Alzheimer's dementia? In Alzheimer's dementia, it is temporoparietal atrophy, temporoparietal. Okay. While in Lewy body dementia, entire of the brain is involved and it has occipital involvement as well. Because of that occipital involvement, the patient has visual hallucinations. Okay. So as soon as a dementia patient, they write visual hallucinations, you start thinking of Lewy body dementia. Very difficult to diagnose radiologically. Alzheimer's we could pick up radiologically because of temporoparietal atrophy. Here the atrophy is not like very particular, so we are unable to tell on a MRI, am I looking at Lewy body dementia? But the key clinical history will be visual hallucination and dementia. Okay, are you clear? While in Alzheimer's we had hippocampus involvement, temporoparietal. In Lewy body dementia, hippocampus will be normal and you will have visual hallucinations in the question. That will be helping you in differentiating different types of dementia. Okay, now very good. Now let's see if you can answer another question. Okay, second question. Name a Parkinson's plus disorder which is characterized by midbrain atrophy. Name a Parkinson's plus disorder which is characterized by midbrain atrophy. So that means it is similar to Parkinson's in clinical manifestations, but pathologically the midbrain is shrunken. This disease is called as progressive supranuclear palsy. So when you will read Parkinson's in your medicine class, you will find they will mention that there are Parkinson's and there are Parkinson's plus disorders. And the most important is PSP, progressive supranuclear palsy. It has midbrain atrophy. Okay, very good, beta. How to identify it on a MRI? Let me explain it to you. Okay, let's see how many of you are able to understand my point. If this is your midbrain, this is your pons, medulla, vermis, tonsil. Okay, very good. Now I want you to look at the midbrain and the pons and the medulla again. Okay, just look at them. Look at the size of the midbrain. This is your midbrain. So midbrain looks thinned out. It is so thin. Look at the size of the pons. Pons is so fat. Medulla, even the medulla is more fat than midbrain. Even the spinal cord is more fat than midbrain. That means we must be looking at midbrain atrophy. Okay. Now suppose we had no work to do. Suppose we were totally free and we were enjoying medicine. Suppose we had nothing to do with exams. Apan enjoy kar rahe hain baith ke. So we make some eye, we shade the colors, and apan enjoy kar rahe hain. We're just making a painting, beta. Hai na? What do you think this is? This looks like a hummingbird, and that is why it is called as hummingbird sign on MRI. हर कोई नहीं देख पाता बेटा hummingbird, सब जल्दी में होते हैं. So if you have time in life, you will see birds, butterflies. Time नहीं होगा तो कुछ भी नहीं दिखेगा. Are you clear with this or not? So midbrain is so thinned out, okay, so thinned out that it kind of gives an impression, because the chest of the bird is found by a larger pons. The midbrain is thinned out, giving rise to an appearance called as hummingbird. So hummingbird appearance on MRI is seen in progressive supranuclear palsy. Okay, very good. Now you are able to understand the rationale and the reason. Second Parkinson's plus disease that I want all of you to always remember is is MSA. Did you children read about this? Multi-system atrophy. Okay. Parkinson's plus disorder, MSA, is multi-system. Okay. Okay. Now let's see if you can answer. Okay. Let's see. So MSA is of two types: MSAC, MSAP. Okay. MSAC is pathologically called as olivopontocerebellar atrophy. MSAC is called as olivopontocerebellar atrophy. MSAP is putaminal atrophy. Okay, different parts of the brain are atrophied. So there are two types of MSA. MSA is multi-system atrophy. We say MSAC and we say MSAP. MSAC has olive. Olive is a nucleus in medulla. Pontocerebellar, olivo, pons, and cerebellar atrophy. And MSAP is putaminal atrophy. Okay, let's try to understand how it looks like. Okay, let's try to understand how it looks like. So the image that I'm showing you now was asked last year in JIPMER exam, in November JIPMER exam. And you can now see that, why all this that I'm telling you is so important for your exams. This is your orbit. Okay, this is your orbit. This must be a temporal lobe. And this is the temporal lobe. This must be your cerebellum. Okay, this must be your cerebellum. Okay, I want you all to look at the cerebellum and tell me, are you able to see the foliae very easily? Yes, these foliae are prominent. Why? Foliae are appearing prominent because the cerebellum is thinned out. There is cerebellar atrophy. Jaise in brain we saw if the sulcal spaces are prominent, that is cerebral atrophy. If the foliae are prominent, that is cerebellar atrophy. Okay, now let's see if you can answer. Okay, let's see if you can answer. Okay, cerebellar atrophy could be because of multiple causes. One of the cause of cerebellar atrophy could be alcoholism. Second could be long-term phenytoin therapy. Okay, so the causes of cerebellar atrophy could be alcoholism, phenytoin therapy, we don't know. But in this patient, it is not only the cerebellum which is atrophied. Look at the pons. Pons is that rounded fat thing. In this patient, it is small. So not only there is cerebellar atrophy, there is also pontine atrophy. This white thing that you see here is your fourth ventricle. So the fourth ventricle is looking larger because the cerebellum has shrunk and the pons has shrunk. So it is looking larger. So you have pontocerebellar atrophy. Not only that, in this disease, what happens is, in pons, cruciform fibers in MSA undergo gliosis. मल्टीसिस्टम एट्रोफी में पॉन्स के अंदर जो क्रॉस शेप फाइबर्स होंगे, जो ट्रांसवर्स और लॉन्गिट्यूडनल जा रहे हैं, वो खराब हो जाएंगे, उनमें ग्लायोसिस हो जाएगा. ग्लायोसिस मतलब होता है स्कारिंग, खराब हो जाएगा. नाउ दिस इज हाउ इट लुक्स लाइक. The pons, if you look at it in the center, you will see a cross-like abnormality. This is what is popularly called as hot cross bun pons, seen in MSA type C. Okay. Now what I want you to see is, beta dekho. Now what I have actually explained to you is only radiology of Parkinson's. Parkinson's में क्या होगा? Parkinson's से मिलता जुलता Lewy body dementia याद कर लिया. We saw progressive supranuclear palsy. We saw multi-system atrophy. This is radiology of Parkinson's and Parkinson's plus disorders. This is a T2 weighted MR where you can see the CSF was white, very good, very smart. This is a T2 weighted MRI showing you multi-system atrophy type C. Okay. Now, before we go forward, I just want you to look at two miscellaneous disorders. है ना, दो miscellaneous देखेंगे फिर tumor दिखाऊंगा, ठीक है? We will see some tumors after this, है ना? We'll see some tumors after this. Okay, everybody now. Are you with me, बच्चे? सुबह है बेटा अभी it's early in the morning, बेटा. You're all fresh. Don't worry. Okay. Okay, बच्चे. Listen to me and tell me what part of brain is abnormal. What part of the brain is abnormal? This is midbrain. Abnormality जो भी है, that will always look very white. So the midbrain is very white. Can you see it is very white? But the only thing is, this area where you have the substantia nigra is paired, and this area is also normal. Okay? So what I'll do is I'll write down, in this patient we have midbrain abnormality, but somehow it appears to spare the substantia nigra and red nucleus. What could it be? अच्छा, बिल्कुल धीरे धीरे जा रहे हैं बच्चे, धीरे धीरे जा रहे हैं. Okay, धीरे धीरे जा रहे हैं बच्चे. Okay, now see, so in this patient there is a सिर्फ एक word है बेटा, just there is just one word to teach here. Okay, there's not much, but it is very important disease. That's why I'm including in my discussion. There is a neurological disease affecting the midbrain, but it appears to spare the substantia nigra and the hot cross bun sign. Bun beta burger wala jis hota hai, that was it. Okay, so this is a disease involving the midbrain, sparing the substantia nigra and the red nucleus. Now I want you to look at the screen here. Beta jo bimar jagah hai, that is looking white. जो नॉर्मल है वो डार्क लग रहा है. ओके, सो इट लुक्स लाइक एज इफ इट्स एन एनिमल. देखो ऐसा लग रहा है कि एनिमल है जिसकी गाल व्हाइट व्हाइट है, आंख ब्लैक ब्लैक है. लुक एट दो चब्बी चब्बी व्हाइट चीक्स एंड दोस. इट लुक्स लाइक अ पांडा. दिस इज फेस ऑफ जायंट पांडा. एनीबॉडी हैव यू हर्ड ऑफ दिस बिफोर? कौन सी ऐसी बीमारी है, फर्स्ट ईयर से पढ़ रहे हैं, जिसमें फेस ऑफ जायंट पांडा होता है एमआरआई में? उसका नाम है विल्सन्स डिजीज. Wilson's disease involves the brain. You remember it has hepatico-lenticular striatal involvement. It involves the basal ganglia, it involves the midbrain, and in the midbrain, it spares the substantia nigra and red nucleus, giving rise to a characteristic appearance called as face of giant panda appearance. Okay, everybody gets it? Everybody understands? Very good, brilliant. Just one more, such typical appearance, and then we'll go to some common tumors. Okay, listen to me now. Listen to me now, bache. There are some diseases now which are called as NBIA. What is NBIA? Neurodegenerative diseases characterized by brain iron accumulation. Okay? हमें पहले नहीं पता था, but today we know there are diseases which are characterized by abnormal iron accumulation in the brain. The most important NBIA is a common disease called as Helleverdon spast disease. Don't worry if you have not heard of it. नाम है किसी का, Helleverdon spast disease. Also called as PKAN. What is PKAN? Pentothenate kinase associated neurodegeneration. Okay, pentothenate kinase associated neurodegeneration. Okay, are you clear with this? PKN मतलब क्या है? दोबारा लिख लो. Pentothenate kinase associated neurodegeneration. This is a disease in which you have iron deposition in globus pallidus. Okay, this is a disease in which you have abnormal iron deposit in the globus pallidus, and the patient typically comes to you with dystonia. Clinically क्या लिखा होगा? Dystonia. Okay, let's look at it, beta. Let's look at it. Okay, this is how it looks like. I will explain it to you, but the key is the name that I'm building up. Okay, ये chordate nucleus है. Okay, ये putamen है. ये thalamus. And this area is your globus pallidus. Now the globus pallidus has a black rim surrounding it. The center is white because of the dead tissue. This is a scar tissue called as gliosis, and periphery has dark because of iron. ऐसा हो जाता है. So the reason I'm telling you all this is because it is a very beautiful name. It is called as Eye of the Tiger sign. And there is an exam called as NIMHANS, which people give when they want to directly pursue MCH neurosurgery or neurology or psychiatry. In NIMHANS, in the last 3 years, they have asked this question 3 times. Eye of the tiger appearance is seen in. Eye of the tiger sign is seen in Helle-Warden's disease, which is a type of NBIA. What is the new name for Helle-Warden's PKAN. Where is the problem? Globus pallidus. What is the problem? Iron. Everybody understands? Okay, everybody follows? Okay, image not clear. Beta, image is clear. Beta, have you never seen the eye of the tiger? बच्चे, आपने कभी टाइगर को आंख में आंख डाल के नहीं देखा? अरे यूट्यूब पे देख लेते, असली में थोड़ी जानना था ना. ऐसे ऐसे होती टाइगर की आंख. टाइगर हैज, उसकी आंख के आसपास से ब्लैक सा रिम होता है. दैट्स व्हाई दिस इज हाउ इट लुक्स लाइक. टाइगर आंख. Okay, eye of the tiger appearance seen in Helle-Warden's disease. So only 2 things I made a little difficult things were Wilson's or eye of the tiger, face of panda. Panda and tigress are friends in Kung Fu Panda, so I thought I should include them together. So this is your Wilson's disease, and this was your eye of the tiger appearance. Every year these are asked, so there is no, these are some things that you're supposed to keep in mind. Okay, now I will show you some tumors. I will show you some tumors, and we will try to focus on the ones which are most likely to be asked in the exam. Okay, now see, look at this image, and any one of you can tell me what is this structure that I'm making as a red color. बच्चे देख के बताना है आपने, है ना? Okay, I think सबके रिसर्च टेस्ट हो गया है, सबको कुछ ना कुछ दिख रहा है वहां पे. Okay, everybody now. MS से मतलब मल्टी सिस्टम एट्रोफी बेटा. Okay, मल्टी सिस्टम एट्रोफी. Anybody now? When we look at this red structures that I'm now drawing, they are nothing but the dural folds. You remember the dural folds that we discussed at length when we were discussing the anatomy? This is your falx. This is your tentorium. Okay, this must be the dural folds. Can you see a solid enhancing lesion? Okay, can you see a solid? Now this is not a ring lesion. Ring के जैसा नहीं है, inflammatory नहीं है, पूरे के पूरे में डाइका अपटेक है. So we can see a solid looking homogeneous enhancing मतलब डाइका अपटेक कर रहा है. Solid looking homogeneous enhancing lesion कहां पे है? It appears attached to the dura. So it is a dural based homogeneous enhancing lesion. Are you clear? So now my thinking is, why would something be based on the dura? It must be arising from the dura. It must be arising from the dura. That means if I now explain to you, beta dekho ek baar, बच्चे देखो, if this is your dura matter, okay, ठीक है, dura matter है, so below it you have the leptomeninges, the arachnoid matter, ऐसे, So the arachnoid matter will give rise to these granulations, which will be going like this, SA. So on the top of this arachnoid granulations in the dura, you have cells called as arachnoid cap cells. These cells, if they undergo become a tumor, that tumor is called as meningioma. Okay. So if I see a tumor attached to the dura, I think of meningioma. Meningioma arises from arachnoid cap cells. They arise from arachnoid cap cells. Okay. Why would arachnoid cap cells become a tumor? Why would they start dividing and become a tumor? It is known to be associated with neurofibromatosis type 2. Okay, meningiomas are known to be associated with neurofibromatosis type 2. Okay, बेटा एब्सेस रिंग एनहांसिंग होगी, ये सॉलिड लीजन है, हाउ कुड इट दिस बी एब्सेस, है ना, ये तो सॉलिड लीजन है ना बेटा. सेकंड इज, लिसन टू मी, इज प्रायर रेडिएशन एक्सपोजर. Meningiomas are associated with NF2 and radiation exposure. Okay, what is this MRI? This is a contrast enhanced MRI. Okay, now let's see T1 weighted post contrast MRI. Everybody understands? Okay, now the question is, let's see how many of you can answer this. Okay, meningiomas are more common in females as compared to males, and they enlarge in pregnancy. Okay. Okay. Now the question is, meningioma is a high-grade tumor or a low-grade tumor? It's a low-grade tumor. Then why is it enhancing? ठीक है, सोच के बताना है. Earlier we discussed that if it is a tumor which is high grade, which is causing disruption of the blood-brain barrier, it will pick up the dye. है ना, हमने सीखा था कि blood brain barrier को कोई चीज disrupt करेगी तभी वो बीमारी enhance करेगी. So meningioma is a low-grade tumor, but it is enhancing. How it is possible? Anybody can guess it. Meningioma is a low-grade tumor, then why it is enhancing? Okay, low grade को तो blood brain barrier intact होना चाहिए. Why it is taking up the dye? Anybody can think and answer. If you are able to answer, you will be able to make sense. Angiogenesis है, लेकिन बेटा वो तो blood brain barrier रोक लेता ना. Because it is outside the blood brain barrier. Brilliant, very good बेटा. Because meningioma is a dural tumor, it is outside the blood brain barrier. It has nothing to do with blood brain barrier. It is outside the blood brain barrier. Vascular tumor है, इसलिए enhance करता है. Are you clear? And such tumors which are outside the brain anatomically, but we call them brain tumor, we call them extraaxial brain tumor. बच्चे बताओ, meningioma is an example of extraaxial brain tumor. It is outside the anatomical dimensions of the brain. We say extraaxial. Very good. Now, second question is, why it is more common in females? Why it is enlarging in pregnancy? Because in pathology they will tell you meningiomas have progesterone receptors. So that is why it is enlarging in pregnancy and more common in females. And I told you neurofibromatosis, NF मतलब neurofibromatosis बेटा, neurofibromatosis type 2. Clear? Meningioma समझ आया थोड़ा थोड़ा? Okay, second question. Now if I give you a gross specimen, ठीक है, एग्जाम हो रहा है, उन्होंने ग्रॉस स्पेसिमेन दे दिया, रेडियोलॉजी दी नहीं, अब क्या करें? सर ने तो पढ़ाया नहीं, सर ने तो रेडियोलॉजी पढ़ाई नहीं, अब क्या करें? बच्चे, we will not be afraid, we will find this is the problem, this is the disease. Yes, we can pick it up. Now tell me, do you think this disease is within the brain or outside the brain? We can see a cleavage plane separating the tumor from the brain. It looks extraaxial. That means it must be arising from, यहाँ पे क्या होता होगा बेटा, क्या होता होगा यहाँ पे, उससे आ रही होगी. What do you think is NF2 Vartika is neurofibromatosis type 2? NF मतलब neurofibromatosis बच्चे, है ना? Now tell me, what is this? So this is called as, this must be the FOX. So that means we are looking at meningioma. So the moral of the story is, even if you don't know what you are dealing with, but you are able to guess, you can guess from radiology into pathology, from pathology into radiology, you can guess, but provided you understand clearly. Okay, that is the key here. Okay, the second question is, when you look at meningiomas on microscopy, when you see meningioma, okay, on microscopy, can you see these rolls of calcium called as psammoma bodies? These are the same psammoma bodies that you see in papillary cancer, thyroid also. So when you look at meningioma on an X-ray, it might be seen as a calcified tumor. Are you clear? समझ पा रहे हैं? एग्जाम पूछेंगे, meningioma can be seen as a calcified tumor on X-ray. Answer is true. Why? Because उसमें कैल्शियम के रोल्स हैं जिसको पैथोलॉजी वालों ने बताया psammoma body. Are you clear with this or not? So this is the correlation. Okay, more common in female because of progesterone receptors. Progesterone receptors होते हैं इसके अंदर. Okay, now very good. Okay, now let's see and answer the next question better. Let's see if you can answer. So once we learn to correlate कि पैथोलॉजी वालों ने बताया समोमा बॉडी, रेडियोलॉजी वाले बता रहे हैं कैल्सिफाइड है, बात तो एक ही, याद कर ले, एक जगह पे याद करके खत्म करते हैं, दूसरे में देखने की जरूरत ही नहीं है. Okay, let's see the next MRI. Okay, let's see the next MRI बेटा. Okay, this is your petrous part of your temporal bone. This is pons. This is cerebellum. Okay, beta G, are you clear here? This petrous part of the temporal bone is black because we are looking at an MRI. I have labeled the pons, I have labeled the cerebellum. Where is the tumor located? Where is the tumor located? Tumor is located in the CP angle. What was the history of the patient? I asked the history. They say hearing loss. Oh my God. What type of hearing loss? Conductive or sensory neural? This is sensory neural. Okay. So you have a sensory neural hearing loss with a CP angle tumor. Okay. This is the tumor. Beta ji, now tell me, a big question coming your way. Beta, tell me, this tumor, when I trace the tumor towards the petrous, appears to become thin. Okay, can you see, as I go towards the petrous, it is becoming thin. Why? Because it is going into the canal, it is going into the internal auditory canal and forming appearance. And I knew that you will become angry later on that इतनी देर बैठे सर ने कुछ खिलाया नहीं, तो इसलिए मैं आपके लिए ले आया, because otherwise उसे सर ने कुछ खिलाया नहीं, इतनी देर बिठा दिया यार. ये तो बच्चे, don't worry. Can you guess what is it? देख रहे हैं, cone है, softy है. Okay, so we'll call it ice cream cone appearance on contrast enhanced MRI. CNN. What is this tumor? Okay, now don't get angry. At least I gave you ice cream with what is this tumor? Vestibular schwannoma. Okay, this is vestibular schwannoma. Everybody clear? Schwann cell tumor, nerve sheath tumor arising from the vestibular division. We call it vestibular schwannoma. Association. Again, vestibular schwannomas are also associated with NF2. Vestibular schwannomas are also associated with NF2, and when you look at them in microscopy, in pathology, they will tell you about things like Verrucke bodies. Have you heard of them? Verrucke bodies and Antony A, Antony B zones. याद है? Pathology में they will talk about Antony A, Antony B zones, and they'll talk about Verrucke bodies. So this is how you identify CP angle tumor. Okay, clear. This is vestibular schwannoma. Now you cannot get it wrong. Okay, next question. Okay, let's try to answer the next image. Yes, very good. NF2 is associated with meningiomas and vestibuloschwannomas. Okay, next image. This is a coronal contrast enhanced MRI, and the next image is a sagittal contrast enhanced MRI. Okay. Okay, let's try to understand. This is a previous NEET question where the question was saying visual problem. Patient has visual disturbance. This patient comes to you with visual disturbance. Okay, this is the history. Now, what ventricle is this, beta? Try and answer. Try and answer. What ventricle is this? Lateral ventricle. What ventricle is this? Third ventricle. Where is the tumor located? Tumor is located below the third ventricle. Well, what is in the floor of the third ventricle? In the floor of the third ventricle, we have the optic chiasm, but the tumor is going much below it. So the question is, probably I am seeing a tumor which is arising from a structure which is below the optic chiasma. I don't know what it is. What structure is below the optic chiasma? Okay. Now see an answer. And when I look at the sagittal image, this is your sphenoid sinus. Okay, this is your nose. N is the nose, S is the sphenoid sinus. The tumor is sitting above the sphenoid sinus. So that means it must be arising from something which is above the sphenoid sinus. Okay, anybody guess? Now tell me. Same patient, two images. What do you think? It is a pituitary tumor. Okay, so below the optic chiasma, above the sphenoid sinus is a pituitary. So we say pituitary adenoma. And it looks like a large pituitary adenoma, more than a centimeter, more than 10 millimeter, we'll call it macroadenoma. More less than 10 mm, we will call it microadenoma. Okay, everybody understands. But let us understand the appearance further. If this is your sella turcica, everybody, if this is your sella turcica, in sella turcica, you have your master endocrine gland called as pituitary. In sella turcica, you have the master endocrine gland called as pituitary. But the God must have given some protection to the master. Do you agree? There must be some protection to the master. So to protect the pituitary gland from our intracranial pressure, sella is covered by a dural fold. To protect the pituitary gland from intracranial pressure, you have a dural fold called as diaphragma sellae. Did you read about this in your first prof? याद है? सेला को ऊपर से एक ड्यूरा के फोल्ड ने कवर किया जिसका नाम है डायफ्रामा सेल्ले. But there is a gap in the center for the infundibular stalk so that the master can communicate with the hypothalamus. है ना? इसलिए ऐसा बनाया. Okay. Now suppose you have a pituitary tumor. The tumor will start growing. It will fill up the entire sella. Then what will happen? It wants to grow further. If the tumor wants to grow further, listen to me. If the tumor will grow further, it will take the anatomical route. It will come out through the gap in diaphragma sellae, go to the suprasellar area, and grow like this. So pituitary tumors are indented in the center by diaphragma sellae, giving rise to an appearance called as figure of 8 appearance, also called as snowman appearance, also called as cottage loaf appearance. Are you clear? Pituitary macroadenomas, macro, okay, will give rise to a figure of 8 appearance, snowman appearance, cottage loaf appearance. Let's see again. बच्चे देखो, क्लाइवस ये वाला है बेटा जी, क्लाइवस ये वाला है. तो क्लाइवस तो बचा हुआ है. कॉर्डोमा होता तो क्लाइवस को डिस्ट्रॉय करता ना. So it is not a chordoma like some of you are getting confused. It is a tumor in the sella turcica. Now you will see an answer, beta. Dekho, this is how the tumor is growing. But then it gets indented by the dura, by the diaphragma sellae, giving rise to the figure of 8 appearance, or we can call it snowman appearance, or we can call it cottage loaf appearance. Everybody understands this? Interesting to know. Okay, everybody understands the concept now. Okay, this is pituitary adenoma, and you know by now that to cause visual disturbance it must be compressing the optic chiasm. So it is the macroadenomas which compress the optic chiasm. Microadenoma तो इतना छोटा मिलीमीटर का होगा, it will not reach till the optic chiasm. This is a pituitary macroadenoma. Clear? Everybody understands? Brilliant. Okay. Now, should I go further or you have enough? I have just 2 more tumors to show as per my schedule. Do you allow me to finish 2 more tumors? Just 5 मिनट में 5 मिनट में दोनों हो जाएंगे, छोटे छोटे से हैं. Just, otherwise, I will have to talk about them again in the next class. Okay, just 2-3 tumors. Correct? Okay. In the next image, thank you very much. You have a CT scan. Okay, this is your frontal lobe. अच्छा, ये वाला कर लेते, बस ये वाला कर लें बच्चे, बस ये वाला. बेटा अब तो खुल गया ना बेटा. माय रूल इज ना, अगर एक चीज खुल गई तो उसे खत्म करना है बेटा, छोड़ नहीं सकते बेटा. नहीं 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 बेटा, फिर पेपर में आ जाएगा. डू यू रिमेंबर दोस डेज when in micro prof only chapter that you leave, that only comes as a long question, huh? Okay, so we cannot leave it now, we have opened it. Okay, yes, very good. So this is the frontal lobe, this is the temporal lobe, this is the pons, this is the cerebellum, this is your fourth ventricle. Okay, just 2 minutes, just 2 minutes beta. Instead of typing, write down in your notebook. Tell me beta, look at this image and answer beta. Any one of you can answer. On this CT scan, where is the tumor located? The tumor is located in a CSF space, star-shaped CSF space, which is located anterior to the pons, behind the frontal lobe. फ्रंटल लोब के पीछे, पॉन्स के आगे, CSF स्पेस में एक कैल्सिफाइड ट्यूमर है. कौन सी स्पेस है ये? This space is called as the suprasellar cistern. Okay, any of you can answer. Suprasellar cistern में क्या था? Suprasellar cistern में you have the infundibulum. And if embryologically you have a mistake and you have a Rathke's pouch remnant in the infundibulum, which grows into a tumor, what is this tumor called as? Craniopharyngioma. Clear? Calcified tumor in the suprasellar cistern called as craniopharyngioma. Do you see it in adults or children? Both. It is a bimodal tumor. Predominantly seen in children, but can also be seen in adults. And this was an image asked in last year's NEET PG exam. Okay. So I hope you are clear that whatever I'm telling you is what is asked in the exam. कई बच्चे सोच रहे हैं जैसे सर आप जो पढ़ा रहे हो उसके अलावा आ गया पेपर में तो नहीं आएगा. बेटा इट इज नॉट आस्क्ड, उससे ज्यादा नहीं पूछते, उन्हें पता है ना. डू यू एग्री हियर कि नहीं? लास्ट 2 decades से दिस इज व्हाट दे आस्क. एंड सर अगर अमेरिका गए तो वो भी इससे ज्यादा नहीं पूछेंगे, बिकॉज वी नो व्हाट इज टू बी आस्क्ड टू अंडर ग्रेजुएट. ओके, सो वेयर एवर यू गो, वट एवर एग्जाम यू विल गिव, the radiology images that they will ask you will be from your classes. Okay, everybody clear? This is a non-contrast CT. Okay, NCCT. This is not dye uptake. This is calcium because this is a non-contrast CT. Everybody clear? Okay. Now what we'll do is we'll continue forward in the next class. Before we go, what we have learned today, we have to summarize what we have learned. We have learned 2 things. Whenever we encounter a new thing in life, our first response is to give a judgment, while the correct response is to think and answer. Okay. Okay, are you clear with this or not? Whenever we encounter a new thing, our first response is to give a judgment, while the correct response is to become a thinker. So this is what I've taught you today. I've always tried to look at an image, and we've always tried to think what is happening instead of judging what is happening. And why it is important is because today all of you are doing judging all day, all night. Remember, or what you are doing, beta? Listen to me, beta. What you are doing? You open Instagram and you say, कितने गंदे कपड़े पहने हैं, and then you write what fashionable clothes are you wearing, and then you say कितने गंदे लग रहे हैं ये दोनों साथ में, such a cute couple, and you're just judging whole day. But in exams and in real life, if you are always judgmental, you will make errors. अगर किसी को उसके पहनावे पे या कैसा दिखता है उससे जज करेंगे तो गलतियां होंगी, then you make wrong relations. Same is in MCQs. You need to think on the questions, you need to think on the images, you will always get them right. But if you start judging, sir white दिख रहा है तो ट्यूमर है, नहीं बच्चे सोचना पड़ेगा. Okay, and that is the entire moral that I wanted you to have today. That is what we taught. We instead of going into the judgmental way, we tried to analyze कि कैसा दिख रहा है, कहाँ दिख रहा है, calcified है कि नहीं, solid है कि ring enhancing है. We always kept thinking. And because we were thinking, we were always able to understand things better. That is the key. That is the key. Stop judging, start thinking, you start winning. Okay. I wish you all the best. Good night. Have a great night's sleep. In the next class, we will finish CNS and start chest X-ray. Thank you very much.